All right, good afternoon, everybody. I'm glad to be here, glad to be back with Nelson Mullins. I totally agree with what Robert was saying in his opening statement. It's such a privilege to be with a group that understands the move to value-based payment, understands that we are not yet completely there, but they understand that this is a journey and that they are helping so many, both in this room and those of you watching from home, understand how to get there, and that the path is long and winding, but Nelson Mullins is there to help you out. So I am going to be kicking off today, starting at the highest level. I love to call it 60,000 feet above the ground. As Robert told you, there's going to be a number of amazing panels this afternoon, lots of details. I'll be back on a panel if you want to go deeper into a specific topic. But where the team at Nelson Mullins has asked me to start is essentially what is happening in value-based care, because some of us maybe believe the hype a little bit more than others, but sometimes I'm wandering around the internet late at night and I like to kind of see what everybody else is saying. So I still visit the site www.twitter.com every once in a while just to see what people are talking about. And if you routinely kind of go on there and just say, hey, what is everyone talking about with value-based care? There are a lot of what I would call sort of hot takes, right? And one of my favorite hot takes is value-based care is just something you slap on your entity before you sell it to someone else, right? And so it is, I understand that, like people are out there saying it. And I think one of the challenges is if you are not deeply involved in this space, it can be hard to see the forest for the trees. It can be hard to say, everyone's talking about this, and maybe there are panels at a conference, but how real is this? How many people are actually doing it? What does the landscape look like? And that's where I'm going to start today. I started my career in government, and I was just telling some folks today that one of the hallmarks of government, if you know that you're in government, is that you sat through something called the State of the State. And that's where the governor stands up and likes to talk about everything he or she has done in the last 12 months and then tell you about everything else they're going to do in the next 12 months. So what I proposed to Nelson Mullins is to do a little bit of the State of the State. So State of the State of value-based care. And what I'm going to hope to do in just 45 minutes or so, and we'll have time for Q&A, is just to kind of give you this like very, very high level view. So that way, as you dig into the panels to come, you'll sort of understand where is all this situated within the context. I'm Juliette Price. I'm the Chief Solutions Officer at HSG Global. We are a boutique consulting firm that focuses solely on the move to value in health and social care. So I like to say this is what I do all day, every day. As Robert told you, part of my job at HSG is helping our clients build and participate in models, whether that's a model that's been put together by the federal or state government, or models that providers are coming up with on their own. I see sort of everything from very, very mature models to just sort of new ideas out in the field, and so it's a real honor to be here today. I think sometimes it's helpful to just start from the very top, right? For some of those of you listening, you may not have a deep understanding or knowledge or context about what is value-based care. One of the most unhelpful things we're doing in this industry is we're calling it a bunch of different things and pretending that it either means all the same thing or it means different things. So I think one place to start is just to say, yeah, we're calling it different things, and depending on who you talk to, they're going to be using different nomenclature. Sometimes we call it value-based care. Sometimes we call it alternative payment models or APMs. Sometimes we go right to the money and we call it value-based payment, VBP. Sometimes it's value-based contracting to talk about the legal papering that has to happen between entities, right? All of these are starting to be used interchangeably, and there's slight variations, again, depending on who you're talking to. But for today's example, and you'll probably hear me also go in and out of language, just know that these are all talking about the same thing, right? This is all about changing the way we're paying for healthcare services. That's the big piece here. So generally, as a philosophical concept, what is value-based care? It's a couple different things. But the most important thing to understand is it is a move away from our historical fee-for-service system, where depending on the number of units of service that you provide, you are paid a specific dollar amount. And so ergo, I was not some great math whiz in high school, but the more services you provide, the more fees you can collect, right? That's some basic math. We sort of understand what that does to our system. It incentivizes as many units of service as possible, whether or not that's actually good for the patient, the institution, our country, our payers, whoever you want, right? The move to value-based care is to move away from this concept of volume and move towards this concept of value, right? Paying for outcomes, sometimes people call it, paying for population health. Again, we've sort of circled the drain on what we want to call it. But it's really about succinctly moving away from tying ourselves to the concept of volume. It's also an approach to reimbursement that centers the provider, and I say provider, and I want that sort of capital P, lots of providers. That's not necessarily just your primary care providers. We'll talk a little bit about that today. I'm talking about specialty care providers. I'm talking about in-home, out-of-home, hospital, telehealth. Big P when I say provider. So it's not just the doctors that we're always used to talking about. And it really allows them to be incentivized to understand what is going on, both in the lives of their patients, but also in the larger ecosystem. It allows them to also share in the financial risk, which has been to date held back from providers themselves. It's also a method to tie payment to providers directly with outcomes. This is a long path that we've been on. Some of us remember the innovation that was paying for performance, paying for reporting. We sort of thought that was innovative, right? This is pushing that all the way to the right-hand side of that outcome and saying, we're actually just not gonna release dollars unless we see the kinds of clinical and social outcomes that we're looking for. Lastly, I would say it's a key component to what we call delivery system reform. And you can think about this in a couple different ways. Smaller ecosystems, your communities, multi sort of cities or states. States are obviously all engaged in healthcare delivery system reform, which we'll get to in a second. But our country and frankly, other nations all across the world are engaged in this. It's not always called value-based care, but the NHS is pushing this very aggressively. France, Italy, Germany, Lithuania is one of the most advanced value-based countries, I should say, in the whole world. So this is happening not just in our backyards, but actually all around the world. And I think that's also important to say and remember, because sometimes it can feel like this is a fad, right? If you're up late at night on twitter.com, it can feel like this is just a passing happenstance, but I can promise you it's not. And I think we have also a lot to learn for what other countries are doing. One thing you're going to hear me reference is the HCP LAN. This is a Healthcare Payment Learning and Action Network, a very exciting acronym. It's sponsored by CMS. This is a great place if you're sort of starting to want to know what's happening in the ecosystem, because this organization helps benchmark every single year how is value-based care and contracting and payment advancing from a nationwide perspective, right? I'll get into a little bit about how different states and providers classify different types of value-based payment arrangements, but at the national level, we have this HCP LAN that basically breaks it into 4 categories, right? Category 1 right there on the bottom, that's fee-for-service. That's our old way of paying for things. Then you start to see a little bit of innovation, fee-for-service with maybe a little link to quality or value. For some of the physicians or practices in the room may remember the bumps in quality, right? You might get a couple extra dollars if you hit certain quality measures or you hit certain gateways, those kinds of things. That's typically what we mean when category 2. We're still not seeing any risk that's being moved to the provider. That really starts to happen in category 3. Category 3 is all about APM or alternative payment model or value-based model that's built on the fee-for-service architecture. And what I mean by that is these kinds of arrangements, the physicians and the groups that are in these, they're still continuing to bill fee-for-service, but they're starting that transition away. And so in category 3, you'll see there's a breakdown. The first half, category 3, is where there's upside risk only, which means if there are shared savings, the provider and typically the payer will share those between themselves. And in the second half of category 3, there's downside risk, which means if there's overspending, the provider actually has to cut a check. Right? We're all sort of used to this in our own sort of daily personal lives, right? We can say we're going to set ourselves a budget, and if we go over it, we have to write a check, right? That basic concept is being brought over into healthcare. There's a target budget, and if you go over it, you're going to have to write a physical check. You can imagine how that incentivizes physicians and physician groups to make sure they don't go over that budget. Category 4 is what the sort of utopia of value-based payment is being talked about. That's when we start talking about population-based payment or prospective payment, where we actually send the dollars way ahead of time, and there are different models which we can talk about later. But this is sort of the nirvana where we are paying up front for a set of services, and we're telling providers that they own that risk. And once again, if you go over that, that's coming out of your own bottom line, and any shared savings that you find are yours to keep. So this is how the HCP land organizes itself. The reason I wanted to walk you through this is because I want to start showing you where are we with the adoption of value-based payment across the whole country. It's really important to understand how this is happening across business lines. So first, just to tap into Medicare, there's sort of two approaches to Medicare. There's Medicare Advantage, now accounts for just about half of the marketplace. This is a capitation-based program. Risk-adjusted payment gets advanced to a Medicare Advantage plan, and they have to manage that spend. They then turn around and do downstream contracting with providers, which oftentimes have value-based elements to it, because if they're being held to that capitation amount, they want to make sure that their providers in their network also understand that there is a cost and quality perspective. Traditional Medicare, or what we call Medicare fee-for-service, has a number of value-based offerings. We're now getting to a saturation point, which we'll talk about a little later today. Providers who are in the Medicare fee-for-service industry have had a long time to enter into these programs. The one that is probably most familiar is MSSP, the Medicare Shared Savings Program that has been around for quite some time. Most providers have been in that for 5, 6, 7, sometimes it feels like 100 years. But then you also have newer models that are constantly coming out of CMS and CMMI. The one that was mentioned earlier today, ACO REACH, that is the direct descendant of the direct contracting model, or DCE. So that has been around for a few years now. ACO REACH is the highest risk model, so that's 100% upside downside risk. Very risky types of arrangements, and we'll talk a little bit about what we're learning about ACO REACH in a minute. And you also have CMS and CMMI are pushing new models, mostly around primary care these days. There is a new model coming out that just came out this fall called Making Care Primary that focuses on primary care investments with some quality bonuses. And then, of course, we're all familiar with the bundles of care episodes, which we can talk about a little bit later. But this is sort of some of the offerings that you're seeing in Medicare. What is Medicaid doing in value-based payment? For a really long time, there was sort of this rumor that it wasn't worth taking risk in Medicaid. And for anyone who was at this year's health conference just a few months ago, whatever it was the #1 topic of discussion. And I think somehow the public health emergency through COVID and the re-enrollment period has opened people's eyes to just how big the Medicaid program is in this country. 1 out of every 2 births in America is on the Medicaid program. We're obviously seeing this re-enrollment period, and so there will be a drop in the Medicaid program members, but this is still a superiorly important program, covers a lot of individuals, and what you're seeing at state Medicaid agencies is that they are moving aggressively into value-based payment arrangements. I've pulled for you just 3 examples here, but mostly you can find these, typically they're called either a roadmap to value or a plan for value. On the state Medicaid website, you have New York State here on the very left. In the middle here is Tennessee. They've organized themselves a little bit differently. They're mostly around care episodes, clinical conditions, and also Texas is one of also the most aggressive states moving into APMs. They like to call it alternative payment models. And so they are issuing year over year different types of models and updates on how many of their providers are in value. It would be a fool's errand to not look at taking risk in Medicaid. I'll leave it at that. We could talk a little bit more about what this looks like, but this is certainly catching on. So now that I've told you that it's around, I think sometimes it's helpful to just take a half step back and just sort of say, why is all this happening? Why is this all important? It was someone's idea dreamt up in Washington perhaps, but what does it mean for the rest of us, right? And I think there's just sort of two charts that I always go back to really anchor our response to this question. And this, what you see here in this chart from the Commonwealth Fund, this is our healthcare system performance compared to spending in industrialized nations. This is probably a chart you have seen before, right? In terms of how much we spend and how our health system performs, we are a significant outlier. And we have been for a very, very long time. This is not a new trend. Also, unfortunately, we see high levels of patient suffering. And you can measure this a whole lot of different ways, but one way to think about it is the avoidable death rate. And we continue to be, as a country, on the very, very high end of this. Obviously, don't read too much into that last little spike there. Obviously, COVID had an impact, but you can continue to see that the US has high avoidable deaths in terms of our counterparts all around the world. So we're highly inefficient and we're not getting good patient outcomes. To me, there's no way to look at this other than to say we have a highly wasteful, highly inefficient, and frankly, highly dangerous, and frankly, morally bankrupt system of healthcare here in the United States. And that's a pretty dire assessment of the situation. And my other thing that I would want to say is I think we can do better, right? We can do so much better than what we're doing today. And value-based payment is one way that we can get there. The most important thing I want to say to you about value-based care is that it is a means and not an end. Too many people think that it's all about getting yourself into a value-based arrangement, holding that up as some sort of, trophy or accomplishment, and then calling it an end. It will not solve all of our problems, and it is simply a tool in our toolbox. This is an actual screenshot that I took just the other day. This piece of news kind of hit my desk, but I thought it was fascinating, right? We are obviously having a mental health crisis in this country. We all know it. We're all struggling with what to do with it. And this little piece of information hit recently that this is a New York State analysis that value-based payment in Medicaid through our redesign program has been linked to significant reduction in mental health ER visits. Isn't that what we're trying to do? That is the kind of results clinically and socially as a country we're all looking for, right? And so there continue to be this little trickle of evidence that keeps coming out about value-based care. And this is a real quick summary. Obviously, there's more to be said on all of this. But effectiveness and efficiency, as I mentioned earlier, and those graphs show you, we have a highly inefficient system. And something has to be done to drive down that kind of waste. And value-based payment is a way that we can get there. Ultimately, VBC is all about lowering cost. And when I say cost, that's not just utilization, but that's also taking into account price. And that is something that we continuously throughout these models, and we'll take a look at some results in a second. Patient-centered care has to be the thing that we're after, right? We have to continuously look at clinical outcomes and making sure that patients are actually better served. And part of the link between cost and quality in a good VBC arrangement enables us to make sure that a reduction in spending isn't just because we're not actually serving the patient needs. Sometimes we need more services in a specific area to take waste out of the system, and that's how VBC can help us. We continue to see better clinical outcomes from folks who are involved in VBC arrangements. One big push, especially in the Biden administration, is all about health equity. We have examples of where VBC has been implemented and actually helped drive down racial disparities in clinical outcomes. So this is another really great outcome that we can get through VBC. Most importantly, if you are a provider in the room or online, I think we all know there's also a provider crisis brewing. There is burnout and there is frustration. People did not get into this field to do medical billing and coding, right? They came into this field to care for other human beings. And so much of what VBC does, it creates, and you'll hear a little bit more on the opening panel about VBE as a strategy, it creates not just the legal entity, but also the care redesign pathways to make sure that providers can lead these changes into what is best for their patients. Reducing provider burnout, we already just talked about that, and really high levels of innovation, which some of we'll talk about today. So where are we in all of this? Forest for the trees. Everyone's talking about it. Everyone's talking about it on Twitter. But what is actually happening in the ecosystem? I was just having a conversation with one of my fellow panelists on our walk over, and we were saying, it feels like it's been forever, right? It feels like we've been in this for a really long time. While that can feel true, and day to day we might feel that way, and especially if you're in a contract negotiation, it definitely feels that way. But when we take the long view of history, we've only really been at this for about 10, 15 years in a really structured way. CMMI has been around for 10 years now. They've launched over 50 models. 33 are still operational. You can go look at the outcomes that they are posting. And not that CMMI is the end-all be-all, because I would highly suggest that we move past some of the models that they're putting forward, but it can help us understand what's actually happening in the field. So, you guys remember this set of categories. We're going to focus on category 3, the high end, where there's downside risk, and then category 4, where we're actually moving into capitated arrangements. There is significant differences in VBP adoption across these different lines of businesses. And that's why I started with making sure that you guys kind of understand how this plays out. Because depending on who you are, depending on who you provide services to, you need to understand how VBC is unrolling in your line of business. This is the latest data for 2021. You can see there, category 4 is in the green. Category 3B, that's where there's upside and downside risk, is that dark purple. And then everything below that is light purple and gray. So you can see there's considerable variation in how VBC adoption is working across all of these business lines: commercial, MA, traditional Medicare, and Medicaid. We're going to go through this really quickly. You'll have access to these slides, and this information is available online, so don't feel like you have to take in every single piece of information here. But on the aggregate, this is where we stand across all lines of business. So about 19.6, let's round up, be generous to ourselves, and say 20% of healthcare spending in the United States is an advanced value-based payment arrangement, which means there's downside risk or ultimately population-based capitated payments. You can see how that breaks out a little bit there. But the story is misleading if you look at aggregate data, as it often is. Let's start with commercial. We see that 53% and a little bit higher is still in fee-for-service. So this is the majority of commercial insurance and payments are still in a pure fee-for-service model. You can see that only 12.7 are in those higher levels of risk. We'll bop over to Medicare Advantage. Here you see a lot fewer of those fee-for-service dollars, so they're hovering about 39.4, we'll just round up to say 40%, and you're seeing that 35% are in those advanced arrangements. So Medicare Advantage is certainly a little bit more advanced. Traditional Medicare, now this is an interesting one, right? You see that category 1 is pretty slender, but we still have a whole lot in category 2, which, as we talked about, that's no downside risk. That's mostly fee-for-service with some link to quality and value. But still, you still have about 24% in those higher risk-based arrangements. Then you have Medicaid. Medicaid is still hovering about half fee-for-service, and then you have 16.6% are in these higher thresholds of upside and downside risk. My caution you in reading this chart is that Medicaid is also an aggregate of aggregates. And so just as an example, I want to show you sort of how New York State Medicaid is stacking up against those national numbers. In New York State, we call level 2 or higher, which is upside downside risk. There's 18% of that spend is in those highest arrangements. 56% are in level 2, which means there's upside and downside, not capitated. And level 1 is upside only 86% of the spend. So within the Medicaid program nationally, there's great variation. So just be a little careful. Oh, I don't think I can go back. Oh yeah, I can. Just be careful in reading this chart, because within this chart, there's also great variation of what's happening state by state, and that can matter to you as a provider. So if you did the quick number and held all those numbers in your head, which I'm sure all of you guys did, I want you to also compare that to how Americans access health insurance, right? So over just a hair under half are covered by commercial insurance. So if commercial insurance is covering the majority of the American population, and yet it is still furthest behind, you can see that there is quite a bit of opportunity here. 15% of the population is in Medicare, 21% of the population is in Medicaid. Do some rough math. There's some obvious other pieces here, but that should give you a sense of sort of where is opportunity in each of those programs to advance value-based care. So now that we know what's going on from a very high level, the question I probably get asked the most is, does it work? Which I always think is a funny question, right? Because that is such a broad question and probably can't be answered unless there's like a 4 or 5 hour panel with all of my esteemed colleagues here, right? But I just want to pull up out of the weeds a couple examples for you if you're not familiar with some of these successes. ACO REACH, which is, again, the direct descendant of DC direct contracting, DCEs, that was started under the Trump administration. The results just came out last week for performance year 2022. So obviously there's a claims lag runout on this, so we're a little dated here. But I think the headline sort of spoke for itself, right? In that everyone who participated in PY 2022, this was the second year of the program, so it had really just started, generated $870 million in gross savings. So this is a pretty small number of providers and a pretty small number of beneficiaries who were actually in these ACOs, we're now calling them ACOs, generated $870 million in shared savings, right? So this is a pretty high bar, and I think what it shows me is that this is more than possible to find and reduce waste in the system, right? A couple interesting notes here. The cohort that began the program in 2021, so those who had 2 years, this would have been their second year of performance, they doubled their savings rate. So it's pretty obvious that that first year that you're taking on risk, right, it's a little new, you're kind of getting your feet wet, you may encounter some things you didn't expect, but by year 2, the engines are running a lot faster if you can double the savings rate that you're generating as an ACO, right? What we see on the high end, and this is a really fun data set if you're a nerd like me and like to download these Excel spreadsheets, if you organize the file based on savings rate and look at the very top end of the file, there are multiple ACOs that are posting savings rates of 24 to 30%. That is so incredible to know. That is telling you something about the level of inefficiency in the system, right? So that when the right incentives are aligned and there's the right structure where providers are incentivized to be able to capture in those shared savings, they can find 24, I think the very high end was like 31%, right? Sometimes folks want to talk about, well, are these ACOs sort of creaming? You know, are they just taking patients who they know they can find savings on? One of the most interesting things in that file is some of the ACOs who had the highest saving rates actually had very high special needs population. They were admitted within this special need ACO designation. So that means clinically, those populations are very complex and require a lot of specialty care. And I think that is something we don't talk about enough, and there'll be a great panel at the end of the day to talk about the integration of specialty care. So if they can do it with a very high clinically risky population that requires a lot of expensive specialty care, I think we can all sort of say the proof is in the pudding here. When you look at the broad ACO spread, 75% of those ACOs found shared savings, varying levels. Of course, some folks just eked out a little few dollars here or there. Others had quite significant shared savings. 25% of them didn't find shared savings and saw shared losses. And I don't think we should take that lightly either and continue to sort of monitor this as we go forward. It is not enough, and I say this all the time, back to VBC being a means and not an end. It's not enough to be in a high-risk arrangement. You're going to have to do something differently clinically to get those kinds of results that you can see that some ACOs got. The other thing I would note to everybody is when you look at this file, these are still relatively small numbers of beneficiaries participating in the ACO. As you recall, this was the second year of the program, so a lot of provider groups didn't quite know what to expect, and so of course they didn't put all of their providers or beneficiaries in the ACO. So if we're seeing this level of performance off of sometimes 5,000 or 10,000 beneficiaries, imagine the kinds of performance and savings we would see once more beneficiaries and providers move into the program. What's working in the Medicaid space? Full risk or near full risk arrangements also exist in Medicaid, just like ACO REACH is for Medicare. We have seen high risk or full risk arrangements. In New York State, we call this the Innovator Program. 95% of the Medicaid capitation bypasses the managed care organization and goes directly to an at-risk provider. We have seen entities come together to take advantage of this type of contracting, and we now have in New York State entities, at-risk doctors who are now seeing upwards of $500 million coming in the door every single year, full capitation, which allows them to be as flexible as humanly possible. An example that I love to give, we have a client who's in this type of arrangement where they have entire groups of physicians who do not come in and practice in clinic anymore because they are getting they're getting that capitation payment up front in the door. They have entire teams of physicians who just do home-based health. And they go out and they take care of folks who are in their own home who either physically can't get to the clinic or for whatever social, emotional, mental health reason, they're not going to come in and see those individuals. They have entire teams of physicians and they don't have to care about fee-for-service because they've already been paid. So this isn't a question of finding the right billing code. It has already happened. They have already gotten that revenue and they can deploy their physicians in the most efficient way that they can do. We continue to see savings rates increase year over year, and New York State tends to, we're on the cusp of having another 1115 waiver for Medicaid, and we do hope that the state reopens this program to see this continue. What else is working? I think sometimes the private markets are a great way to see, is this working? Are people getting into this space, for-profit companies? And absolutely, and the headliners, and Robert invoked the Oak Streets and the Ioras, which now feel like they're not the new kids on the block anymore. There are a number of innovative companies who are out there, for-profit entities taking on risk. Upward Health is a great example. They take risk on the most high-cost behavioral health complex population, usually the top 1% to 2% of a plan, and they go out into the community. They push into homes, they meet people where they are, they deliver great quality care, and they've built their entire business model. Also interesting, for those of you who follow sort of the social determinants of health, the social space, aligning to the healthcare space, Ounce of Care is a great organization. They are also out there. They're pushing into public housing units where they know folks are eligible for Medicaid, and that's where people live every single day. And so instead of waiting for someone to come to a clinic, they're pushing right into public housing units and meeting people where they are. So once again, they're creating for-profit businesses because this financial model works. You also have a whole series of aggregators. Pearl is one of them, but there are many who are aggregating practices up into ACOs and participating either in ACO REACH or in MSSP programs. So again, when you see the private market develop entities like this, you have a sense that the business model really can work and produce shared savings. As much as it's fun to talk about what works, I think it's equally as important to talk about what's not working, or what are the challenges? What do I see when I talk to my clients or go into negotiations? The first thing, and I think someone mentioned it already, is that most of these models do attribution through primary care providers. And I was a big fan of the show Orange is the New Black, right? And so I have consistently been saying over the past couple of years, primary care docs are the new black. Right? These are the folks who can drive attributions into these models. And so what you're seeing, especially on the M&A side of the equation, is that providers are being acquired at lightning speed for sums of money that might make your eyes pop because they are driving attribution. This is a huge power shift in the healthcare ecosystem. And frankly, not all primary care providers are ready for this. Some are taking bad deals. Some are making deals that they don't understand. We were having just a little conversation about this earlier today. This is just such a huge 180 in the healthcare ecosystem. I can't emphasize this enough. So if you're part of a primary care group, it is in your best interest to really understand how the move to value-based payment can and might work out for you. There is such a lack of primary and specialty care integration. And like I said, there's a closing panel that Robert will be on and talk a lot about. But frankly, in a fee-for-service world, when 70 to 90% of the total cost of care was outside of your line of view, you frankly didn't care a whole lot, right? Great doctoring means care coordination, of course, but you never had to worry about that spend. all of a sudden, if you're in a total cost of care arrangement, it really matters what's happening in specialty care. And most primary care providers have no idea what those networks look like, what those referral patterns are, what the quality of the care is, what the cost of the care is, and frankly, they just don't even have access to that data. And so this is a real point of concern, and we see a lot of ACOs get started in risk arrangements. They don't have this understanding, and very quickly they can find themselves in the red if they don't build some sort of specialty care integration. Hospitals continue to bury their heads in the sand about the future. It's not revolutionary for me to say this, but the spending and the shared savings comes out of the hospital sector. And so it is you see a lot of hospitals forming VBE entities or trying to protect their revenue, but you also see a lot of hospitals and hospital systems simply burying their head in the sand, calling VBC a passing fad, and I'm here to warn anybody who thinks that is certainly not a strategy. Payers are also not necessarily ready for this new world. We all know the payer ecosystem is terribly fractured across lines of business, across states. It can be hard, and that would probably be the understatement of the century, to work with payers on getting into value-based arrangements. And so as much as I know sometimes it sort of elicits a collective groan, I think we also ought to give them some grace. They're figuring this out as they go as well. And so really to get good outcomes between payer and provider negotiations, you really have to have an understanding of where they're coming from, what their limitations are, and how providers frankly can help them. This can't be a zero-sum equation. It has to be true partnership. Data. Who has it? How good is it? We've all heard the phrase garbage in, garbage out. I would argue we were still in the garbage in moment here. And what is it really telling us? This continues to be, even though 2023 feels like we're living in the future in some aspects, we continue to be in the middle ages of data acquisition, data cleanliness, understanding how to use it. Everyone is struggling with this. This is not just you. If you have felt that this is your challenge, it's not just you. But I can guarantee you that the folks who figure this out the fastest will win in a value-based ecosystem. There's also a lack of focus on key care delivery areas, and what I mean by that, especially from that last slide, right, talking about primary care and the alignment to primary care, there's sort of this over-association with primary care, and that's sort of the locus of all control. And what I tend to see is that there are really important areas of our delivery system that are going under talked about or under innovated, I would say. At-home care is huge, right? We have been talking about the silver tsunami for as long as I can really remember, and still I am shocked by the number of people who look at the long-term spending in states and go, I can't believe we're here. Like, we were here a long time ago. We knew this was coming. The aging of the population is here, and we simply are not ready, and we don't necessarily understand how to reduce costs. The IDD, intellectually developmentally disabled population, other special populations that are not up here, these tend to go overlooked. And this, I think, is both a moral challenge for us, but also just a complexity challenge. There are subpopulations who just have high levels of need, and we're not always really well equipped to have those conversations and figure out how to go through those. Maternity episodes, this is one of the lagging areas in VBC. Texas just put out a report. They're very unhappy, we'll put that in quotes, with how their state is working towards the implementation of maternity APMs. As I mentioned before, if 1 out of every 2 births happens on the Medicaid program, that is runaway spending that if we don't have an understanding of how to get really good clinical outcomes and lower total cost of care, we're just simply not advancing the field. Pediatrics is another population close to my heart. Most kids are not medically complex. Only about 2% of the pediatric population is medically complex. So what are we doing for that 98%? Who really need us to be there in their first couple years of life, and yet we're not necessarily seeing a lot of advanced models here. There's really what I would call a lack of systems thinking in terms of regard of how patients access care. This is the whole adage of, you have 4 people who are blindfolded who are each touching a certain part of the elephant, right? So the person who's touching the trunk thinks it's a snake. The person who's touching their foot thinks it's a tree, right? How do we stop this thing of only looking so narrowly at our area of the health ecosystem and really start engaging in systems thinking? Because that's how our patients access care. They don't think just about one specialist or one doc. They are living complex lives themselves. I think the other thing is just the thinking that fee-for-service care works in a value-based world. As I mentioned before, a VBC contract is really just the starting line. It is not the finish. And so thinking that you can do the same kinds of clinical care that you did in value-based care, that you did in fee-for-service and be successful in value-based care is simply not true. And so we also need to see more movement of innovative care models. There's some out there, some that I highlighted, but I think we need to see much more work in this space. And so lastly, I guess I would just sum that all up by saying sometimes I fear that there's a lack of imagination, right? This is a huge, complex problem that's in front of us, and it will require not just a value-based contract, but high levels of imagination to get us to where we want to go. So what does the future hold for value-based contracting? You've got some of the leading lights in this room, and they'll be on the panels this afternoon to dig deeper and talk a little bit about what this looks like and operationally. But I guess the big thing I would leave you with is that VBC absolutely will continue to accelerate. There is simply no turning back now. If 20% of our healthcare spend are in these kinds of arrangements and we are still in the early days, that means we have hit a tipping point. But there's still a lot of opportunity, right? Remember that slide that I showed you? Half of Americans have commercial health insurance, and yet commercial health insurance is the least dominant market when you talk about value-based care. So there's lots of opportunity, but I would issue a caution, which is that opportunity exists today. So if you're in this room or online, it's because you understand that there's a business opportunity, a clinical and business opportunity here. If you wait too long, that opportunity window will close. And so it's great that you're here, and the best place to start is where you are at, but I do fear that if people ignore this for too long, they will wake up one day and realize that the value-based ecosystem is here, and they were not ready for it, and they were left behind. Ultimately, enhanced capabilities of entities will continue to be prerequisites for successful VBC. The one that I will call out once again is that ability to understand what the data is telling us. Acquiring, cleaning, organizing, analyzing data is not fun or sexy work, but it is the work that will make sure that you understand what's happening in your ecosystem and that you can be successful in VBC. Innovation and out-of-the-box thinking will be key for early successes. Everyone that we saw, if we were in this room all those years ago when Iora and Oak Street first got started, a whole lot of people told those folks that they were crazy to ever think that that would work. And as Robert mentioned, they have been sold for very large sums of money to very large organizations, right? So continuing to be innovative, figuring out what our patients needs, that is what will lead us to success. There's absolutely no turning back. I think there's so many indications of this. This was a little other nugget that popped into my inbox the other day. The investment side also, again, kind of can help be a bellwether to all of this. Investments in value-based care entities are now growing faster than capital expenditures on new hospital construction. If that doesn't tell you that the winds are shifting, I don't know what will, but I hope you can see that. I leave you on a note of optimism, and if you saw this in the New York Times now about a month or two ago, this was the front page on a Sunday New York Times article, which I found pretty funny. This is sort of the key, bad journalism burying the lead, right? So the headline was, "A huge threat to the US budget has receded, and no one knows why." Right? And this whole article was about how we were on a decades-long path of Medicare overspending to the point where both sides of the aisle, no matter who you were looking at that yellow trend line and going, my goodness, how are we ever going to pay for this? And since about 2009, you can see that we have effectuated a $3.9 trillion savings gap. This is the biggest story that no one's talking about. We have saved our own government from bankruptcy, right? Is there one reason why? No, of course not. There are lots of compounding factors, but I posit that you cannot take a look at a 50% of the Medicare space being Medicare Advantage, a capitated program, and say value-based care isn't working. We can do big things as a country. We have done it before. This proves that we are still capable of doing it, and I inherently believe that taking the road to value-based payment will allow us not only to meet our expectations, but to exceed them in spectacular ways. Thank you for being here, and I'm happy to take any questions that you guys have. Mike with the first question.
Talk a little about the fundamental situation where you're a practitioner and you have some contracts that are value-based care model and you have a lot of fee-for-service, and you treat your patients, you have one side of your head for the value-based care and one side of your head for the fee-for-service, and therefore you provide them with an entirely method of treatment. How does that work?
Yeah, that's a great question. So what we talk about that as having one foot on the dock and one foot in the canoe, right? And so if you ever grew up on the water, or if you didn't, it's a pretty obvious analogy, right? It is very hard to have one foot very solid and one foot kind of teetering off on the edge here, right? So two things that I often tell providers. One, if you're gonna go into risk-based arrangements, first of all, don't start off at 100% risk, right? This is a gradual pathway, so set yourself up for success by not taking 100% risk if you've never done this before. However, there's emerging evidence, and there was a recent article in JAMA about this. If you're going to take risk, you might as well figure out how to get as many risk-based contracts, even if they're not 100% risk, as possible from the get-go. Because essentially, to your point, Mike, you're going to start doing things clinically that lead to better outcomes in your clinic, and we all know how doctors operate. They want to operate with the best of intentions towards all patients, right? So if you're gonna start doing things differently for one specific contract or one payer in your portfolio, your docs or providers are gonna start doing that for everybody. And so there is a strategic advantage to just getting into as many value-based contracts as possible from the get-go to realize some of those shared savings, instead of saying, I'm gonna do this one contract on my Medicaid line of business, I'm gonna do that for 2 years, I'll wait, and then I'll do a Medicare line of business. That tends to be not the best strategic strategy. And so oftentimes we will advise folks to get into multiple risk-based arrangements. It also just depends on who your payers are and obviously what ecosystem you are in. But yeah, it's a real sense of uncomfortableness to have one foot on the dock and one foot in the canoe. Other questions? Yeah.
The payers either, thank you. The payers either can't or won't give up the data. Usually it's won't because of this, well, we can't tell you what we pay in unit prices because that's confidential. And usually the providers just back down and then they fly blind. Mm-hmm. And that to me seems like the number one impediment for moving to value-based contracting payments, whatever you want to call it. Yep. Do you have any insights on how we get past this? Because I just usually roll my eyes and say, we're not going to get anywhere unless you give up the data.
Yep. But it's a great question, and I'll just repeat it. So the question is really around, in order to be in a value-based contract and a payment arrangement, how do you, and this individual is saying he's encountered multiple plans who either can't or won't share the data, and how do you break through on that? This is one of those annoying, like the answers in the question, right? So the first thing I always urge people to do is understand, is it can't or won't? Because sometimes we misinterpret won't, and it's actually a can't, right? Because, and this is where, I urge people to have grace for payers, because just as much as we've been stuck, right? The provider side of the equation has been in that fee-for-service ecosystem, so have the payers. And so all of their systems are hyper-calcified to do the fee-for-service thing, right? This is that like general sense of like, you do what your environment asks of you. And not all payers, and I would even venture to say like many payers are so struggling with their data infrastructure because it was built for a world that is starting to not exist anymore. So, number one, understanding if it's can't or won't. If it's actual can't, you face a little bit of sort of like a timeline question of your own, right? Because many payers are starting to go through data infrastructure redesign that has time written all over it, right? And so you sort of have to make that decision. Can I wait this out? Can I partner with this payer until they get it figured out? If it's won't, this is so important and so key. Providers simply should not enter into value-based arrangement if they do not have transparency, AKA data. There are ways, especially when you're engaging in contracting. So just to give you like a really tangible example, I often write into contracts payment rules. Right? So if we need a claims file every single month about this population, it's going to cost you if I don't have that file on the first Monday of the month. And I can tell you from having done this long enough, I have old clients, right, who end the year and maybe they broke even, maybe they found a couple shared savings, but you know what they did make money on? The fact that the payer didn't send the files. So it's a little bit of exerting pressure and showing them that you're just as serious as they are about getting into this, but you absolutely have to have data transparency. Otherwise, it is simply not in a provider's best interest to not understand previous spend and what those categories are. Yep.
I was about to pull you early.
Oh. 4 more minutes.
So question, your data actually show what I've had in my gut for a while. The method of paying, not value-based versus fee-for-service, but premiums are based on the insurance company having an amount they have to spend on medical care, and then they have profit and administration. They have no incentive to reduce premium. Medicare has a huge incentive because nobody wants to pay taxes. And that $1.3 trillion gap and over 50% of commercial payers not engaging, it's more than coincidence.
It is more than coincidence. And I was just sharing with someone, so I worked in public service for a long time. Health insurance, part of your compensation package, right? What happens when you move over to a small business, right? We are self-insured. So we go on the exchange and we pay for our own insurance. And I can tell you that I received a 26% premium bump this year. I can also tell you that when I accessed telemedicine, when I was nominally ill, instead of presenting myself at either an urgent care or an ED, right, like they still charged me, right? It was not part of the package, right? It's not part of, and my deductible is something that would make your eyeballs fall out, right? So what am I getting at? The commercial space is facing tremendous pressure. And there was just a report out the other day that for a family, I think it was like a family of 4 who's buying insurance on the marketplace, commercial insurance, right? I think the total was like $20,000 a year. Like how do you say to anybody that you're getting $20,000 worth of insurance, right? Worth of care. That's all to say, you're right. And I predict that commercial marketplace is facing more and more pressure, not just from individual buyers who still, if you look at that graph, still a nominal, I think it was like 6%. But employer-sponsored insurance, they are facing huge premium charges, and so they are going to start to get very serious about what they can do to bring down total cost of care. It's a very fractured market. It has a lot of complexity. It's not as easy, as you were pointing out, as the federal government is looking at Medicare expenditures and going, uh-oh, we're driving into the asteroid here, folks. What do we do, right? So there are different levers, and it's a highly fractured market. But I absolutely, I think there's tons of room for growth in there. And I also think, for solutions-based oriented companies, selling into that space is going to become more and more attractive because people are just absolutely looking for ways to bring down that spend. Yep. Okay, that's what I have for you today. We'll be back, and I'm going to hand it over to Mike to introduce the first panel.